Okay, so we've been talking about the external environment, the open type of fractures and the closed type of fractures. But for the last class revision, I'll just give you a brief overview of the fractures once. Okay. Then, okay, let's say a fracture is a complete or incomplete discontinuity in the cortex of the bone. Yes, there are, certain features of the fractures which can be, seen on the radiograph. So fracture will be generally it's a radiolucent. Okay, it appears down as a black line. Okay, mostly it appears as a black line or sometimes a dense white line in case of impaction, right? And yes, the second sign will be there sometimes will be the discontinuation of the cortex, and that one, the cortex will be deviated or displaced, so that one will actually show up as the step in the cortex. And yes, the trabecular arrangement is also interrupted, so there will be interruption of the bony trabeculae. And yes, sometimes there will be deviations in the cortex. Okay, so such one will actually be called as the bulging of the cortex. And there will be some soft tissue swellings because of the local inflammatory changes. And yes, sometimes if it is happening down within the joints, yes, or the articular surfaces, yes, there will be a lot of joint effusion as well. Okay, so these are the basic radiographic signs of fracture. Okay, so you have to remember them. Okay, there will be abrupt disruption of all the cortex, acute changes of the smooth normal contour of the bone. Yes, fracture lines are black and linear. Okay, and they actually, when the fracture line changes their course, they tend to be sharply angulated. Okay, and there will be fracture fragments also that are present, and they will not be corticated, right? Okay, these are the also the signs of the fractures as well. Okay, you can choose to write any changes. Okay, but a correct complete list actually goes down along with this one and along with this one. Okay, describing the edges and describing the surrounding tissues seems to be the correct way of defining a radiographic features of a fracture. Then we have okay, these are the examples. Okay, later you can actually try to look them over. You see here, this appears down as the sharply angulated margins and no cortications here. Okay, and then you can see that it is appearing down as a radiolucent line, and there is a displacement. Like I said last time, that there will be, the displacement can also be found. Most of the times it actually depends upon the direction of the muscle pull, right? Okay, what kind of abductors or what kind of adductors that are involved. Okay, the pull will be either towards the medial side or the lateral side, depending upon the musculature orientation that is present down there. Okay, you have to understand this one. Okay, and such kind of injuries generally will be causing down a fracture. Okay, and there will be a displacement. Okay, there will be a displacement. Okay, and displacement is generally very commonly seen in case of a transverse or an oblique fracture. Okay, and you can see here there is a stepping up in the cortex. Okay, there is a stepping up of the cortex here. The cortex actually appears like a step. Okay, and there is interruption of the bony trabeculae. Here there is a hyperlucent line, there is a black line in the distal end of the radius, uh, right, distal end of the radius. Okay, and then so then we are having, sometimes we can also see that there will be a bulging of the cortex. Okay, by bulging of the cortex is going to happen in case of a green stick fracture, which can be defined as the discontinuation of the cortex of the bone only on single edge. Okay, not on the other edge, only one side of the cortex will be disrupted, and that is actually called as a green stick fracture, who has a bulging or the buckling of the cortex, right? Which is very quite common in green stick fractures. Okay, green stick fractures are generally very common in children, right? It will be happening because of the shearing, because of the compressive force on the bones. Okay, we will see that in a little while. but there will be a discontinuation of the cortex only from a single edge. So that's the reason it is actually called as a green stick fracture. Right, and there will be surrounding soft tissue inflammation. Okay, surrounding soft tissue inflammation will be there, so there will be a lot of pain, there will be a lot of swelling, and sometimes uh, there can also be a vascular compromise that may be associated with it, which is actually called as the compartment syndrome. Okay, compartment syndrome can happen because of the internal hemorrhages. It can also happen because of the cast that is applied in the management of a fracture. Okay, compartment syndrome is actually happening because of the vascular compromise and the edematic fluid expulsion down into the superficial, into the muscular fascias, and the place becomes so swelled. So it is actually called as the compartment syndrome. Okay, so but there is soft tissue swelling. So another thing, whenever you are trying to look for a fracture, you have to look if there is any kind of a soft tissue swelling or not. And sometimes, yes, there will be joint effusions as well, and the joint effusions will actually show up like a hypolucent area along with the soft tissue density. Okay, increase in the soft tissue density are and surrounding edematic fluid can be actually called known as the joint effusions. Okay, right. And then there is here there is an oblique view of the elbow joint here, actually shows that there is a fracture of the radial head. Okay, right, and it is not showed in the AP view, it is not showed in the lateral view, but you can actually see that there are these hypodense changes only, fat pad signs. We can actually call this as the area of the bursa. Okay, they became much more hyperlucent, so that is called actually the anterior fat pad sign. Okay, or called as the sail sign. Okay, which we will see slowly. Okay, so this one is actually happening down in the supra, in the radial head fractures. Okay, so these, but in the lateral view, you see here there is no fracture that is seen on the radial head, but in the oblique view you can actually see that there is a fracture line that is present down on the radial head. So it is always important to evaluate the musculoskeletal system in two views, so that you can actually understand and compare the symmetry, and compare the orientation of the anatomical organs in two different views. Okay, right. And then we also learned that the types of fractures. Okay, there are so many types of fractures, which is actually comminuted fracture if the fracture is broken down into two or more three uh, segments. Okay, transverse fractures, where the transverse fracture will be, okay, we will be seeing slowly. Okay, according to the fracture direction of the fracture line, the fractures are defined down as the transverse, linear, oblique, displaced, oblique, non-displaced, spiral, green streak, and comminuted fractures as well. Okay, so they are according to the direction of the fracture line. All right, and according down to the atmosphere, okay, according to the atmosphere, there are few types of fractures, which is actually known as the opened type of a fracture or a closed type of a fracture. Okay, open type of a fracture, actually the bones, the fractured bone ends actually penetrate the skin, and the internal fascia and the internal structures are being in relation with the external environment, so they are exposed to the external environment. So that's the reason you actually call them as the open fractures. Closed fractures, okay, bone ends do not penetrate the skin, but they will be either displaced or non-displaced. So they are, and they don't actually penetrate the skin, and they also do not cause any kind of there will be very few little signs of external bruising and external penetrating injuries. So such kind of things are actually called as a closed fracture. Then there are some other types of fractures which are actually called as the occult fracture. Okay, yes, it doesn't necessarily mean even if the bone has to come out or bone doesn't come out. Okay, it doesn't necessarily mean, but still, even if the bone is not out, but still if there is a penetrating injury, okay, from inside due to the bone piercing, okay, even if the bone present outside or not, but inside the structures that are present inside are in contact with the external environment, you can generally call it as open fractures. All right. Okay, so such kind of classification, okay, such kind of a classification is generally made by a classification that is actually called as the Gustello-Anderson classification. Okay, so we are going to learn today about the Gustello-Anderson classification. The more mechanism of injuries that is related down to the direction of the fracture line is given in pretty much big detail with explanations in the practical slides. Okay, since I have covered those things in the last chapter on last session, so that's the reason I'm not going to deal that now here. Okay, types of fractures depending on the direction of the fracture line, they are much more detailed again in the practical slides, so you can just give it a look for the people who actually did not understand them last time. Okay, so we have oblique fracture, transverse fracture, okay, and then spiral fracture and the green stick fracture, impacted fracture, and then the types of comminuted fracture, along with their displacement rules. Okay, now we are going to talk about the external environment and the internal environment of the fractures. So such kind of a classification is actually called as the Gustello-Anderson classification. Okay, you need not completely learn about this Gustello-Anderson classification because you will be learning all these sessions back again in your, orthopedics uh, semester. Okay, whenever you are learning orthopedics, yes, you will be again learning all these things, but the evidence of those things are actually made upon radiology. So that's the reason I wanted to introduce them here in a very, very brief manner. You have to understand one thing, that the Gustello-Anderson classification is actually used for interpretation of the complications that may be related down to the open bone fractures. That is what you have to take home here. Okay, that is what you have to understand. What is Gustello-Anderson classification? Gustello-Anderson classification is made to assess the severity of complications associated with open bone fractures. As simple as that. Okay, so you need not really learn along with the types, because you will learn that more in detail in orthopedics class, but you have to understand just remember the terms. Okay, just remember the terms, nothing else. Okay, there are actually, 5 types of classification of open bone fractures. Okay, there is type 1, type 2, type 3A, type 3B. Okay, until here it is quite simple. You see here in type 1, okay, the wound length is less than 1 centimeter. In type 2, it is greater than 1 centimeter. In type 3A, the wound is extensive, greater than less than 10 centimeters. In type 3B, it is extensive wound, but it is greater than 10 centimeters. Here, there is one special thing which you should always concentrate in your whole medicine. Okay, it is the type 3C. Okay, that is what you have to take home from here. Type 3C type of open fractures are very, very important because they are having a complication that is related down to arterial damage. That's what you have to remember. You see here, yeah, all other types of Gustello-Anderson classification, generally they do not have any kind of involvement of the vasculature, but only type 3C has got the arterial damage. So the arterial damage can happen when a fractured bone is going to pierce the major artery there and going to cause a lot of hemorrhage. Okay, so there is an associated arterial damage with the type 3C in Castillo-Anderson classification. Okay, that is what you have to remember. Castillo-Anderson classification is used for the assessment or the evaluation of complication related down to the open bond fractures. One, it has five types: type 1, type 2, type 3, type 4, type 5. Or you can say type 1, type 2, type 3A, 3B, and type 3C. Out of which type 3C is very important because it will have the arterial damage. So that is how you are going to remember. And the important point here, what is the biggest difference between type 3A and type 3C is that it will have the arterial damage and it will have inadequate soft tissue covering. Okay, inadequate soft tissue coverage, whereas the top type 3A will have adequate soft tissue coverage. So that is the difference. Okay, vasculature are intact and adequate soft tissue coverage will be seen in type 3A, whereas the type 3C will have inadequate soft tissue coverage and arterial damage. So that's what you have to remember about this whole table, nothing else. Well, other thing that might be important is the length of the wounds. Okay, so that is actually called as the Castillo-Anderson classification of open fractures. That's it. Okay, so last time when Aman was asking, you see here, Aman, open fractures can also be called, you see here, even this is an open fracture. You see, bone was not exposed in this place. See, this is a 3A type of fractures, but still the bone did not even actually the bone did not penetrate there, but still the soft tissue got disrupted, right? So there is adequate soft tissue coverage, but the bone did not come out. The bone actually stayed half inside the the fascia itself, right? So that's the reason it is actually called as 3A, but still it is considered down as the open wound itself, right? Okay, but in 3B there is again inadequate soft tissue coverage, but here the vasculature is intact. Okay, right? But type 3C, yes, it has this inadequate soft tissue coverage, but still the vasculature is damaged. So there will be arterial damage, which actually requires a repair. Okay, so that is what the main thing you have to remember about this classification. Okay, one is about its importance, the other about the length of the wounds, and the third one is which one has the arterial damage. So it is the type 3C which has got the arterial damage. Remember one thing here, remember one thing here which is quite important and quite clinical in the sense where it will be having arterial damage, but fractures do not have nerve damage in open wounds. Okay, so here in Castillo-Anderson classification is not made for assessment of nerve injury. Remember that. Okay, Castillo-Anderson classification is not made for assessment of nerve injury. Nerve injuries will be there in case of fractures, but Castillo-Anderson classification do not cover the nerve injury. You get it? Okay, they are not talking about the vascular, they are not talking about the neural deficits or the neural compromise, but it is actually talking about only the vascular compromise. Okay, so that is what you have to remember here, which is a logical thinking. Okay, and then you have to understand the treatment that may be required from required for uh, type A and type 1, 2, 3, and 3A. Actually there will be wound debridement and external fixation has to be done. Okay, we will talk about that. And then for the type 3B, actually wound debridement has to be done, and then there should be internal fixation that has to be done. Okay, you can see here, okay, these are the external fixation devices. Okay, so you see here there is a comminuted fracture of the tibia. Okay, tibia and comminuted fractures of the tibia, and there is a single oblique fracture of the fibula, right? So that's the reason. And then you see here there is an open wound here, so which can be classified generally as the type 2b. So you see here, so sorry, type 2a. So what we actually do it here is that we are going to do with the external fixation devices. You see here, so we did a wound debridement, and then we also did the external fixation devices. So the external fixation devices are the fracture reduction devices, which will be fixed from externally. Okay, there will be no open surgery here, but this surgery is invasive, but the devices attached are put from outside environment. But this one is a type after few days. Okay, the same patient is actually fixed down and proceeded down with the internal devices as well. Okay, there will be again wound debridement after following few days. Okay, what actually you did is that wound debridement, and then we are going to fix the fracture with the internal fixation devices. Internal fixation devices or the screws or something that are bored down, and this is an open surgery. Okay, you are going to open the person, and then you are going to uh, paste these devices. Okay, there are two types of devices: internal fixation devices and external fixation devices. So on sometimes x-ray you have to also you know uh, try to mark them as well. Okay, these are the external fixation devices, these are the internal fixation devices. So that's it, what you have to learn about here. Anderson classifications. Okay, so you look at here, the same thing here. Okay, no vascular compromise, vascular injury, yes. And then we are actually having here 3a. Okay, there is a fracture, it is exposed, but the wound length is less than 10 centimeters, and there is no vascular compromise. and and here then also we will be having the other 2b, 3b here, which has, who is it speaking? Okay, somebody is speaking. I muted all of them. Okay, right now it's okay. Yeah, right now it's good. Okay, right now I guess it's good. And then type 3c, we have the vascular compromise. Okay, so that's what you have to remember here. Okay, now we're going to deal with a very, very interesting part of the chapter. Very important that everybody should be able to learn this one. Okay, and you should actually try to understand a lot of clinical points here, depending upon the other things. Okay, I have already dealt with the avulsion fractures last time, so right now we are going to get down into a very, very detailed and very difficult part of this chapter. Okay, so I want you guys to pay full attention, which actually requires a lot of understanding here. Okay, it is a lot confusing. Okay, but still I will try to make myself very, very simple when it comes down to this type of fracture classification, especially in case of children. Okay, there is a classification that is known as the Salter-Harris classification of the epiphyseal plate fractures in children. Okay, children are having growing bones. Okay, children are having growing bones, and on the growing bones you will actually see different structures like the epiphysis, epiphyseal plate, the metaphysis, and the diaphysis. Okay, you know these parts of the bone, I guess, right? So if you don't know, maybe if you want me to explain them, yes, I will try to explain them. The growing tubular bone, the structure of a growing tubular bone. Okay, so are you guys aware of it, or are you guys not aware of it? If you are aware of it, I will continue with the classification, but if you are not aware of it, let us go to that basic and come. Okay, you are aware of them, right? Okay, they are present down in they are present in your, the practical slides class. Okay, you can actually try to look at them later on, but let me give you a very very brief introduction. Okay, just parts. You can see here a growing tubular bone actually has got, okay, three parts. Okay, there are three main parts, which is actually having the epiphysis. Okay, this is the epiphysis. Okay, before ossification occurs in all most of the young bones. Okay, this is actually epiphysis, and immediately next to it there is a radiolucent line that is actually called as the epiphyseal plate. Okay, it is called as the epiphyseal plate or the growth plate. Okay, which one will have the provisional zone of calcification? So these are the secondary ossification centers, right? So the secondary ossification centers, the primary ossification centers and the secondary ossification centers, okay, will be actually trying to completely fuse the bone into a single tubular structure, right? So that one will be extending down as the next as the metaphysis. Okay, so metaphysis, epiphyseal plate and the epiphysis together forms the cancellous bone of the cancellous part of the bone, right? Then the metaphysis continues down as the medulla and the medullary cavity, which is actually the hollow part, which are the shaft, which actually forms the main part of the shaft, which is actually called as the diaphysis. And immediately after the diaphysis, we will be having the medullary cavity, and then the medullary cavity will be again continuing down as the metaphysis and as the epiphyseal plate, and then the epiphysis and the epiphyseal cartilage, so on the both ends. So every bone, okay, every long tubular bone will be having both the proximal epiphysis and the distal epiphysis as well. Okay, in the distal part, remember, okay, do not get confused here, this is the biggest confusion part. You see here, this is the proximal part and this is the distal part of a bone, right? So in the proximal part, the epiphysis is proximal. In the distal part, the epiphysis is distal. Is there any confusion with this point? Yes or no? Did you understand this point? Okay, in the proximal part of the bone, the epiphysis is proximal. Okay, in the distal part of the bone, the epiphysis is distal. So epiphysis is the one that actually forms down the both the ends. So now you see here in this radiograph, you tell me, okay, this is the epiphysis. Okay, this is the epiphysis of the distal end of the femur. Yes or no? Okay, this is the proximal epiphysis of the tibia. Yes or no? Right? So you see here, this is the distal epiphysis of the femur. This is the proximal epiphysis of the tibia. So do not confuse this one. Okay, you have to mention if it is the proximal epiphysis or the distal epiphysis, which one you are looking at. And that one will have different zones of classifications. Okay, and we'll be also having different times of ossification over a given time in the age, right? So ossification centers, primary ossification centers and secondary ossification centers do not actually appear at the same time in all the bones. It does not happen that way. So you should be aware of the ossification centers, if you have to understand about the Salter-Harris classification. Salter-Harris classification is actually talking about the fractures that is related down to these parts. Okay, do the fractures of the epiphyseal plate and the cartilages along with the metaphysis is actually called as the Salter-Harris classification. Remember, it is a type of classification that is used to assess the fractures related down to the epiphyseal cartilage and epiphyseal plate of a growing tubular bone, or you can say it are used in children. Okay, so one should be aware of these zones. Okay, like I said, there are 5 parts of a zone. Remember, germinal zone, which is actually present down along the epiphyseal end. Okay, then you have the proliferative zone where there will be cartilages, and that will be actually taking down the mitosis. You will be having a hypertrophic zone. Okay, the hypertrophic zone, that is actually, you see here there is a radiolucent line that is present here, so I'm talking particularly about this place. And Salter-Harris classification is actually talking about only the fractures that are present here, just here. Am I clear now? See, last time some student, I think it should be Shubham or Dravendra, I don't exactly remember. He was asking, sir, how can we recognize if it is the zone of calcification or if it is the epiphyseal plate or if it is a fracture, right? So we are actually using the Salter-Harris classification to do that itself, okay? Yes? So we are talking about this particular radiolucent zone, which is exposed down more in the microscopic view. Okay, it will have so many different zone, and the fractures that are related down to this zone is we are particularly talking about that one in Salter-Harris classification. Okay, so then we have the provisional zone, which is actually present along the metaphyseal end. Okay, here is the metaphyseal end, so I'm talking about the provisional zone here. Okay, then there is a zone of ossification. Okay, there is a zone of ossification, and that is the one actually where there will be osteocytes or the osteochondrocytes that are actually coming, osteocytes. Okay, right? So that is the zone of ossification. So these are the 5 zones of a growing tubular bone. Okay, then yes, like I said last time, I said what are the ossification centers and when the times of the ossification centers in particular bones come over. Okay, I have included them in the practical slides. Use them for purely knowledge purpose. They will be very important in case of competitive exams. Okay, all the things that are included down in your this particular practical slides, all of them are very important down for your all any examinations. Okay, any PG entrance examinations like USMLE, PLAB, okay, or FMG, MCI. Okay, they are very important. Okay, so that's the reason you should be aware of that, but I don't explain that one, but still I have included them in your practical slides. Okay, so ossification centers of the elbow, ossification centers of every bone has been included. Okay, and what is the time when the carpels come, which carpel will be seen at which time. Okay, then ossification centers of the hip, ossification centers of the knee, ossification centers of the foot. Okay, now we are going to talk about a classification that is actually called as the Salter-Harris classification. Okay, remember, this is quite simple to understand. Okay, it is not difficult a lot at all. We are particularly looking at the fractures that is related down to this radiolucent line that is present down here. So this blue line that is actually shown here is the epiphyseal plate or the growth plate, which is also known as the physis Okay, listen carefully. Okay, the area that is present between the epiphysis and the metaphysis is actually the growth plate. So if this one only is fractured, okay, if only this one is fractured, it is actually called as the Salter-Harris type 1. Okay, so only the growth plate is involved. It is actually called as the Salter-Harris type 1. But if the growth plate is included along with the metaphysis as well, you see here, this is the growth plate that has been relent, and but you see here there is some part of the metaphysis is also involved here. You see here, this is the normal bone. All the one that is with the blue is the normal bone. But you see here, the where some part of the metaphysis is also broken. So a fracture that is related down along with the growth plate and the metaphysis is actually called as Salter-Harris type 2. Okay. But in type 3, there will be the growth plate fracture along with the epiphyseal part fracture. Okay, so this one is the growth plate fracture along with the epiphysis fracture. Here in type 2 there is this metaphysis fracture, and in type 3 there is the epiphysis part fracture. So this is actually called as Salter-Harris type 3. In type 4, all the three zones are involved. Metaphysis is there, growth plate is there, and the epiphysis is there, and they three will be detached down as a single fragment. So this is actually called as Salter-Harris type 4. Then type 5 is that there will be reduction in the growth plate. Okay, reduction in the growth plate because the growth plate is compressed. So this is type 5. Okay, let me repeat once again. Listen carefully. Okay, listen carefully once again. Normally we have a growth plate, and proximal to it is the metaphysis, distal to it is the epiphysis, right? In Salter-Harris type 1, there will be only growth plate that is actually fractured. So the whole growth plate is separated from the metaphysis. So that is actually called as Salter-Harris type 1. Type 2, there will be a proximal metaphysis fracture along with the epiphyseal plate. Growth plate is also fractured and the proximal metaphysis is fractured. See here, part above is fractured. So that is actually called as type 2. Then in type 3, what happens is that a segment growth plate is fractured, but the one distal to the growth plate is fractured, which is the epiphysis is involved. So here, metaphysis is not involved. Here, epiphysis is not involved. In type 2, epiphysis is not involved. In type 3, metaphysis is not involved. In type 4, all the three components are involved. Okay, just give me a second, I will tell you. Okay, and you see here, then in compression, the type 5 actually there will be compression, so the whole growth plate will be compressed. You see here, actually, why it has got the, you see here, from this table, actually, we can understand that the type 1 has actually got the best prognosis, right? Where here the growth plate in the type 1 is intact, which means to say, you see here, actually, when we are talking about the ones, actually, the zone of ossification, you see, the zone of ossification is present towards the metaphyseal site or not? Yes, you see here, the provisional zone of calcification is present towards the metaphyseal end. Yes. and the zone of ossification is also present down on the metaphyseal end, right? So actually, this one has got the best prognosis. Type 1 has got the best prognosis because it does not having any kind of a problem that is related down to the metaphysis. But here in type 5, what actually happens is that this, the resting zone is actually coming down and competing or being compressed over the provisional zone of calcification and the zone of ossification. Yes or no? In compression, both, what actually happens is that the z- provisional zone of calcification and the zone of ossification are being completely overlapping with each other, so which will be actually causing a deficient closure of the epiphyseal plate, so it has the worst prognosis. Did you understand? Because the provisional zone of calcification is present onto the metaphyseal end. Yes or no? So there will be worst prognosis. So how can I actually remember this Salter Harris classification in a very, very fast way? Salter Harris classification can be actually remembered in a very, very easiest way by just remembering the spelling of Salter. Salter, Salter. That's how that classification is there. So in Salter type 1, there will be a separation of a growth plate. Okay. In Salter A type 2, there will be separation of the growth plate above the growth plate. So above the growth plate, proximal to the growth plate, what is there? Metaphysis is there. So what is not involved? Epiphysis is not involved. So that is how I'm remembering above the growth plate. Above the growth plate actually talks proximal to growth plate. Proximal to growth plate will be the metaphysis. So only metaphysis along with growth plate fracture is present down in the type 2. Then in type 3, L represents the below, so it is actually distal to the growth plate. Distal to the growth plate is the epiphysis, so there is a fracture of the growth plate along with epiphysis. Okay, so that is type 3. Then type 4, it is actually happening through all the structures, through all the three structures is type 4. So epiphysis, growth plate, and the metaphysis is involved. So it is actually through the surface. So it is actually called as the type 4. ER, where there will be compression or the erasure of the growth plate. So it is type 5. So how is Salter classification remembered? Salter classification is remembered by its name itself. Okay, Salter, Salter, type 1 for S, type 2 for A, type 3 for L, type 4 for T, type 5 for ER. So the classification can also be used as the S grade, A grade, L grade, T grade, E grade. Okay, or they can also be said as type 1, type 2, type 3, type 4, and type 5. Okay, remember again. Okay, well, for dwarfism, yes, it is completely related down to the, completely related down to the hormonal problems itself, okay? Related down to the pituitary adenomas or the pituitary and the thyroid and parathyroid gland problems, okay? Right? But generally, they will have ossifications. Okay, they will have ossifications as the age goes by, but still, all of this will not be happening. Okay, so their bones will actually look low and smaller, with only few zones of calcifications, but not all the zones of classifications. Okay, so generally, we cannot take the dwarf to be, particular down as the adult itself. Okay, no, actually, there is a different evaluation that is related down to the dwarf bone related problems. You cannot take the dwarf as a particularly child X-rays. No, they do not have the properties of the child X-rays. Yes, some zones of ossifications will be lost in dwarf people, but the bones are generally considered down, and the bones will be showing down the buildup of an adult person itself. Okay, so dwarfs has got nothing to do with this Salter-Harris classification. Okay, right. So remember, growth plate, only growth plate involved type 1, metaphysis and growth plate involved type 2, epiphysis and growth plate involved type 3, metaphysis, growth plate, and epiphysis involved type 4, compression of the growth plate type 5. As simple as that. Which has got the best prognosis? Type 1 has got the best prognosis. Which has got the worst prognosis? Type 5 has got the worst prognosis. That is what you're going to remember about Salter-Harris classification. Salter-Harris classification generally is used to assess, okay, to assess the growth plate fractures in children. Okay, right now that is what is a very very fast and view of the the classification. Let's try to get more deeper into it. Okay, you see here, in a growing tubular bone, the hypertrophic zone, okay, or the epiphyseal plate is presented towards the epiphysis, and it is most vulnerable to the shearing type of injury, to the crush injuries. Okay, shearing injuries are twisting injuries and crush injuries. And in children, they actually get fractured very, very easily. So all the epiphyseal plate fractures consist of 30% in the childhood fractures. So what actually we can say that the fractures actually occurring down on the epiphyseal plate of a skeletally immature individual. So the classification used for assessment of epiphyseal plate fractures in children is the Salter-Harris classification, right? Then what does the Salter-Harris classification do? You see here, type 1, the epiphyseal plate is involved. Type 2, epiphyseal plate along with the metaphysis is involved. Okay, and they have the good prognosis as well. Okay, they are the most common Salter-Harris type of fractures. Type 2 is the most common. The best prognosis has got by the type 1. Type 2 is the most common type of Salter-Harris fractures. Type 3 is the intra-articular fractures, okay, which is having less favorable generally prognosis, but still where it will be involving down the epiphysis. Type 4 involves three parts: epiphyseal plate, epiphysis, and the metaphysis, and they will have poor prognosis. And crush type 5 is the crush injury of the epiphyseal plate, okay, which has got the worst prognosis of all, where actually the fracture healing will be delayed because the complete loss of the growth plate towards the metaphyseal end. Provisional zone of calcification is competing with the zone of ossification and the epiphyseal plate. So that's the reason it has got the worst prognosis, until the healing is also going to take a long long time. So that's the reason it has got the worst prognosis. So is these points clear for Salter-Harris classification? Okay, remember, this is a very very important chapter to understand. You will be learning again back in orthopedics, pediatric orthopedics, but you have to understand that the basis actually comes down from radiology itself. So better you learn it in detail here, so that it will not be difficult in the later coming chapters. All right, so now you see here the same thing what we did before itself, the same thing here. Okay, growth plate involved, type 1, growth plate along with the metaphysis involved, type 2, growth plate along with the epiphysis involved, type 3, growth plate, metaphysis, and the epiphysis involved, type 4, and type 5, compression of the growth plate. How are they remembered? Okay, they will be remembered down as the Salter, right? They will be remembered down as the Salter, where S stands for separated growth plate. Okay, A stands for type 2, where the proximal to the epiphysis or above the epiphysis, metaphysis is involved. So metaphysis along with growth plate is A grade. L grade is actually the epiphysis along with the growth plate, where it is present down the below or the distal to the growth plate. So it is type 3. L. T, it is happening through all the structures together, and it is actually called as the T grade type of fracture. Okay, so it will be having epiphysis, growth plate, and the metaphysis. Okay, epiphysis, growth plate, and the metaphysis. Then ER, erasure or complete erosion or complete compression of the growth plate, is type 5. So it can be remembered as two ways. It can be remembered as type 1, type 2, type 3, type 4, type 5. Easiest way to remember is remembering the spelling SALTER, Salter. Okay, so you have to actually make yourself sure about this classification. And then, which has got the best prognosis? 1 has got the best prognosis, 5 has got the worst prognosis. Fairly good prognosis is 2, and it is also the most common type of fracture. That is what you should know about Salter-Harris classification. All right, so right, is this okay? I think we will try to have a break here, okay, and then we will come back to learn and continue and try to complete this chapter. Okay, let's have a break. We will start at 1:45. All right. Okay, and we will not be having a lunch break, I guess. All right, because I have already told you that complete the lunch, right? So we'll not be having a lunch break. We will meet at 1:45. Right.